So good afternoon. This week, we explore how the immune system, normally our greatest protector, can paradoxically become a major source of disease. Start with this big idea. The immune system is designed to defend us from pathogens, remove damaged cells, and maintain tissue homeostasis. But when its regulation fails, the same mechanism that protect us can cause significant tissue injury. This is the five major categories of immune-mediated disease. Number one is hypersensitivity reaction, exaggerated or inappropriate immune response that damage host tissue. This includes type 1 to 4 mechanisms, each with distinct immunologic pathways and clinical example. Autoimmunity, when the immune system loses tolerance and attacks self-antigen. This leads to chronic systemic diseases such as SLE, rheumatoid arthritis. Next, the third one, immunodeficiency disorder, when components of the immune system are absent or dysfunctional. Can be a primary genetic or secondary acquired and predisposed to recurrent severe infections. Transplant rejection is the next one. Immune recognition of transplanted tissues as foreign. This involves both cellular and humoral mechanism with hyperacute, acute, and chronic patient. Next, amyloidosis. These are misfolded proteins deposition that disrupts organ structure and function, often linked to chronic inflammation or plasma cell disorders. So, why do we need to know this topic clinically? So, this mechanism underlies many common diseases encountered in internal medicine, rheumatology, nephrology, dermatology, and infectious diseases. Understanding the immunologic basis helps explain why patients present with certain symptoms, how diseases progress, and what therapeutic strategies target. So, to connect to pathology principles, many of these disorders involve inflammation, tissue injury, fibrosis, and vascular damage. These are core themes in pathology. So, you should recognize these patterns such as immune complex deposition, granuloma formation, complement activation, and cytokine-driven fibrosis. Set expectations. So, we will move from mechanisms, morphology, clinical correlations. So, linking the immune pathway to disease and manifestation, this is what you should focus on. Which part of the immune system is overactive, underactive, or misdirected? Think of that. So, with that overview, let's break down each category, starting with hypersensitivity reaction, the classic framework for understanding immune-mediated injury. So, these are my contents. And these are my learning objectives. Without further ado, let's go on now to my lecture. So, innate and adaptive immunity. To understand immune-mediated disease, we first need to understand two major arms of the immune system, how they normally work and what happens when they malfunction. Innate immunity responds immediately and non-specifically. Adaptive immunity is slower to activate but highly specific and capable of memory. This distinction explains why some diseases present acutely and others chronically, and why certain pathogens exploit particular immune weakness. The innate immunity, these are the barriers, phagocytes, natural killer cells, or NK cells, complement. And the innate immunity is the first line of defense. So the barriers is the skin, mucosa, acidic pH, antimicrobial peptides. Phagocytes, the neutrophils and macrophages, rapidly ingest and kill microbes. NK cells target virus-infected tumor cells without prior sensitization. And complement system, opsonization, inflammation, and direct lysis via the membrane attack complex. So here comes the defect: recurrent pyogenic infection, poor wound healing, susceptibility to Neisseria, terminal complement deficiency, to severe bacterial infection, leukocyte adhesion, defects, and chronic granulomatous disease. Adaptive immunity, the T cells and the B cells antibody. Adaptive immunity is antigen specific and improves with repeated exposure. T cells, the CD4 helper T cells coordinate immune response via cytokines. The CD8 cytotoxic T cells kill infected or abnormal cells. B cells differentiate into plasma that produce antibodies. Antibodies neutralize microbes, opsonize pathogens, activate complement. So, what will happen? The dysregulation to the autoimmunity to the immunodeficiency to the transplant rejection and hypersensitivity reaction. Next is antigen recognition, activation, effector response, memory. So, antigen recognition, innate cell detects PAMPS via pattern recognition receptor. Adaptive cells recognize specific antigens via TCRs and BCR. Antigen-presenting cells, especially dendritic cells, bridge innate and adaptive immunity. Activation requires co-stimulation, B7-CD28, and cytokine signals. So, this ensures the adaptive immunity is triggered only when a real threat is present. Effector response. T-cell activated macrophage kill infected cells or help B cells. B cells produce antibodies that neutralize, opsonize, or fix complement. The memory, this is the adaptive immunity, generates long-lived memory cells. This explains the vaccine's effectiveness and rapid secondary responses. So, failures in this step will cause what? Immunodeficiency. Overactivation or misdirected action will cause hypersensitivity and autoimmunity. So, with this foundation, we can now explore what happens when this system malfunctions, starting with hypersensitivity reaction, the classic framework for immune-mediated injury. So hypersensitivity reaction, this is type 1 to 4. So hypersensitivity reaction are exaggerated or misdirected immune response that cause tissue injury. They are the classic way we categorize immune-mediated damage. Type 1, which is the immediate, the IgE-mediated, triggered by allergen binding to IgE on mast cell. Rapid release of histamine, leukotrienes, and prostaglandins. Clinical examples are anaphylaxis, allergic rhinitis, asthma, urticaria. The morphology, there is edema, vascular congestion, and eosinophil. Type 2, which is antibody-mediated, IgG or IgM, binds to cell surface antigens. Mechanism, opsonization, complement activation, interference with the receptor. Example of this are autoimmune hemolytic anemia, Goodpasture syndrome, Graves' disease, and myasthenia gravis. Type 3, immune complex mediated, circulating antigen antibody complexes deposit in tissue. There will be what? Complement activation, neutrophilic inflammation, fibrinoid necrosis. Examples are SLE, post-streptococcal glomerulonephritis, serum sickness, and Arthus reaction. Type 4 T-cell mediated CD4 T cells, which is delayed hypersensitivity granuloma, CD8 T cells, which is cytotoxicity. Example is what? Contact dermatitis from poison ivy, TB granulomas, type 1 diabetes, and multiple sclerosis. So each type has a distinct mechanism, distinct morphology, and predictable clinical patterns. Autoimmunity, like SLE or RA, systemic lupus erythematosus, or rheumatoid arthritis. Autoimmunity arises when the immune system loses tolerance and begin attacking self-antigen. Systemic lupus erythematosus, prototype immune complex type V disease. ANA positivity, anti-dsDNA, and anti-SM are highly specific. Immune complex deposit in skin, kidney, joints, or serosa. Complement consumption, there will be low C3 and C4. Lumpy, bumpy, granular deposit in immunofluorescence. That is the morphology in the kidney. These are wire loop lesions in kidney. On the other hand, rheumatoid arthritis, chronic T-cell driven synovitis with cytokine-mediated inflammation, rheumatoid factor, and the anti-CCP antibodies. So the pannus formation to the cartilage destruction to the joint deformity. Systemic feature is anemia of chronic disease, rheumatoid nodules, and vasculitis. Autoimmune diseases are chronic, relapsing, and often multisystemic, reflecting persistent immune dysregulation. Immunodeficiency, immunodeficiency can be primary, genetic or secondary, or acquired. And the type of infection often reflects the type of immune defect. So, primary immunodeficiency presents in infancy with recurrent severe infections. Example of which are SCID, defects in T and B cell development, ergo, interleukin 2 receptor gamma chain mutation, the ADA deficiency. CGD, defective oxidative burst recurrent bacterial fungal infection, or granuloma formation. The complement deficiency, T2C4. This is an SELE-like disease. C3, severe pyogenic infection. T5 to C9, recurrent Neisseria infection. Leukocyte adhesion deficiency, impaired neutrophil migration. Secondary immunodeficiency, more common due to HIV or AIDS, malnutrition, chemotherapy, and chronic illness. HIV/AIDS, CD4 T cell depletion, opportunistic infection, malignancy. There will be Kaposi sarcoma or lymphoma. So immunodeficiency is an increased susceptibility to infection, often with characteristic pattern, depending on the defective pathway. Transplant rejection. Rejection occurs when the recipient's immune system recognizes the graft as foreign. Hyperacute rejection. This is minutes to hours. Preformed antibodies against donor antigens. Widespread thrombosis with fibrinoid necrosis. Graft becomes cyanotic and fails immediately. Acute rejection, days to weeks, or later if immunosuppression is inadequate. Cellular CD4 and CD8 T cell infiltration, tubulitis, endothelitis. Humoral, the anti-donor antibodies, vasculitis, complement deposition. Chronic rejection, from months to years. Progressive intimal thickening, the vascular narrowing, interstitial fibrosis, irreversible, major cause of late graft loss. So each rejection pattern reflects a specific immune mechanism, guiding prevention and treatment. Next is amyloidosis. Amyloidosis is a disorder of protein misfolding leading to extracellular deposition of insoluble fibrils that disrupt organ function. The types of amyloid. AL amyloid from immunoglobulin light chains associated with plasma cell dysplasia. AA amyloid from serum amyloid A associated with chronic inflammation like RA and TB. A beta amyloid seen in Alzheimer's disease. The misfolded proteins adopt the beta pleated sheet configuration, deposited extracellularly, compress, and distort tissue. They stain with Congo red stain and they show apple green birefringence under polarized light. Clinical manifestation. Kidney, you'll see nephrotic syndrome, which is most common. Heart, restrictive cardiomyopathy, arrhythmia. GI or liver, hepatosplenomegaly. Nerves, there will be peripheral neuropathy. So, amyloid deposition causes structural distortion, not inflammation, leading to progressive organ dysfunction. So, any questions? So, fear is the mind killer. Yes, immune system is very complex. Pathology is complex, but fear itself is the one killing your mind. So these are my reference. Thank you, and I hope to see you in the next lecture.